University in 1992. In 1993, he started working as a fellow in the Department of Gynecology and Obstetrics at Istanbul Faculty of Medicine, and he received the title of Chief Assistant in the same thing in 1997, Associate Professor in 2023, and Professor in 2009. He became a certified gynecology oncologist in 2010, and he founded the Child and Adolescent Gynecology Department in the same clinic in 2001. He has been the head of the gynecology department of Istanbul Faculty of Medicine Department of Obstetrics and Gynecology for 2 years. Welcome, Doctor.
Thank you so much for your kindly presentation. I want to say thank you to the organizing committee, this nice, kindly invitation. My topic is Yag Lazer in the gynecologic oncology, and there is three titles in this main topic. One of them is HPV-related precancerous lesion. The other one, vaginal regeneration after pelvic radiotherapy, and other one is the laser conization. And first. Yag Lazer is the first choice in the treatment of intraepithelial vaginal neoplasia. I believe that in 3 or 4 years it will be that in the guidelines, etc., it will be like that. Why? Because I will explain to you. First, when we see this problem after the radical hysterectomy or hysterectomy because of the precancerous lesion, cervical precancerous lesion, or invasive cervical cancer, and is approximately 5-7% of this patient develops vein, and is 10% of this patient go to the invasive vaginal cancer. There is so much treatment option. Mostly is surgical surgery. The other one, 5-fluorouracil, etc. But the problem is the recurrence. Is recurrence very big problem for the vein? Why? Because it's 40 or 50%. You treat and you cut the vagina, for example, for the surgery, and the patient come again. Because of this, the first choice must be effective treatment and without compromising quality of life. And secondly, it must be done in the office settings. Every time you are giving anesthesia, etc. And this is exactly the definition of Yag Lazer vaporization. Yes, there is so much series for the carbon dioxide laser, but I believe that Yag Lazer has some advantage. And first, vaginal colposcopy. You must do the vaginal colposcopy. Biopsy is very hard to do vaginal colposcopy. You can't see some lesion. After that, you must biopsy from all suspicious lesions, and after that, you can do the vaporization. This is my settings, and vaporization I'm doing under the colposcopy. I'm using R11 and short pulse. This is the settings. It's a very good study. It's a new study, and the number is very high. It's a busy slide, but I want to show you is 116 patient. Look at that. At the end of the 2 years, nearly 100% is healing. It's a very, very good results, and with the carbon dioxide laser. And this is from Italy. And what is the problem? What is the complication? The biggest complication is bubble perforation. Yes, it's very low, but it can be. Here, only 1% in this series, there's a bubble perforation. The problem, I believe that Yag Lazer is safer than the carbon dioxide laser, because carbon dioxide laser is carbonize the tissue, damage the tissue, is putting a hole, but is damage the tissue. Both sides of the hole is carbonize the tissue, but Yag Lazer in this situation is very, very safe. I believe that. I present that before 2 years in this salon. It was 7 patients only, but at this moment we have 11 patients. I presented preliminary data, but in this moment there is 11 patients, and we are following this patient. You are seeing the demographic characteristics, and this is the series. I don't have so much time, but we have 3 recurrence only, but our result is very good, and is a very good choice. And secondly is the VIN3, management of the VIN3 with the Yag Lazer. I don't want to talk about the classification. It's a very long story for us, but there is 2 types. At this moment we separate 2 types of vaginal intraepithelial neoplasia. One of them is HPV related, the other one not HPV related. And the management of all of this is very separate. And because of this, you must take the biopsy and you must wait this result of the biopsy, and after that you must vaporize this tissue. Why? First, of course, you must take the biopsy from the lesion. And why? Because you see HPV independent VIN. There is P53 mutation, but most importantly, verruciform acanthotic lesion is very dangerous. You must take off with the surgery. I will explain why. You see, this is the pathology from the Nature Pathology. This published here. You see this classification. The recurrence of acanthotic lesion is very high, and most importantly, near the 40% there is a invasive cancer with this pathology. Because of this, before the evaporization, you must wait the biopsy. It's so important. The evaporization is very simple. You can do that with the settings of genital ward. And my favorite title is cervical dysplasia with Yag Lazer. There is some key point. I don't think about that, but there is a pathologic smear. After that, there is a HPV typing, and after that, you are doing colposcopy, etc., etc. All of this is knowledge in the textbook. But for the management, you must see the partner. If there is a genital ward, etc., etc., it must treat, and she must vaccinate. Why vaccination is very important for the woman is trigger the natural immunity. And if she smoke, she must quit the smoke, etc. And the patient must come regular follow-up. This is the key point. Why? I will explain. You will see. And we don't want to do CIN2 and CIN3. Prefer to doing laser ablation, but we prefer to doing in CIN1 and under 30 years old CIN2 patients. Why? Because of the margin status. If you vaporize the tissue, margin status is unknown and is so important. And secondly, my experience is give the patient unnecessary confidence. It's my interest, but the patient this is fancy tools, and the patient say that they treat me with the laser. It's very good. All of this is negative. I don't come to the regular follow-up. They said that. I heard several times. Because of this you must talk to the patient. But the margin status is very important. You see here, if the margin HPV 16 is positive in the margin, is 100%, is a good study from Italy. Very homogeneous patients in here. The relapse chance the recurrence chance is very high. Because of this, we don't want to doing CIN3 laser vaporization. And if we are talking about the endocervix margin and ectocervix margin is totally different. If there is a margin is positive in the endocervical canal, endocervical phase, the recurrence rate is so high. We have a very big problem with the management of cervical dysplasia. Why? Most of the patients are CIM1. We examine the CIM1 patient mostly. You see here, 95% of this patient is CIM1. And in our classical point of view, we only monitoring the patient CIM1. Why? Because it's regress in 1 year, 70%. But we diagnose the patient, yes, CIM1, perform the biopsy, confirm high-risk HPV positivity, and we say that, come again 6 months later. Claps, claps, we love you, and come. And what she do? She go to the internet, Googling, and she go to the alternative medicine. Always. They always, why? And especially the medicine they take orally, is most of the patient is CM1. They take the medicine, and there's a lack of prospective randomized study, and the studies is extremely weak. And this is, you see, is especially this one, active exhaust coronary compound. It may work in the, yes, I know there's so much patient for the lung cancer, bowel cancer, pancreatic cancer, yes, there is some data, but it can work. I know the lady is pharmacologist from Texas University. I know, I talked with her, etc. But is very famous in Turkey. You know, the Breakfast, you know, the Papilex is very famous, especially in the Miami area at the United States, etc. But it can work. And, you know, but most important, most big fraud is ozone therapy. I don't believe ozone therapy might work some other pathologies, but for the HPV, because the HPV is only epithelium. For the cervix is 0.3 millimeter. 0.3 millimeter. How can ozone can work? I don't believe that. And is a huge, very huge market. And we are doing colposcopy, biopsy from all suspicious lesion, and this is my settings. The idea, don't hurt cervix. Don't hurt the cervix. Is the peeling, I said, is 0.3 millimeter only. The virus is in this area. And vaporization under colposcopy. You see, there is no problem. It's a sort of peeling, okay? You see, fit the arm here, you see here, for example here, you see here, the margin is so high, it's a very big lesion, but you can do that with the laser vaporization, it's very wonderful. I want to participate with you last 9 months. I do 57 patient laser vaporization for cervical dysplasia. And we do, before the vaporization, Yag Lazer vaporization, we do, before the treatment, endocervical curettage, all of the patient. Before and after pap severe, before and after HPV status, before and after colposcopy. Okay? And we follow up 3 or 6 months. Why? Because all of this treatment is all of the alternative treatment is 3 or 6 months. What is the result? This is demographic of the patient. You see, 12 patients have positive genital wart. This is all data of these patients. At the end of the treatment, 90% complete healing in the pap smear. In the colposcopy, 94%. Yes, there is 2 ascus. You see, this doesn't work, but there is, sorry. It's like that. Okay, I can. This is ascus, CIM1, and other ascus. For the ascus, if there is ascus, there is HPV. Okay, but there is no lesion in the colposcopy. Okay, what is the HPV status? In half of the patient, there is a HPV is negative after this vaporization, and there is nearly 30% of the patient is a partial healing. You see here, Okay, you see nearly half of the patient there is more than one HPV type, and here you see there is only one HPV type. I said that partial healings. Only here 22 patients, not at all, there is no recovery. Okay? But most importantly, because of I show you the first slide in these topics, the additional risk is so important. What is the additional risk? If she is multi-partner, 7th of this is multi-partner, and if the partner had genital wart, is very big problem. It doesn't work. I believe that nothing works. If you are doing, for example, the same things for the conization, for the CIN3, you do the conization, but if there is a partner, sometimes the partner denied to go to the doctor, denied to genital wart treatment. Okay, we are seeing again and again some cervical lesion. It's so important. This is the lack of the studies, most studies, this additional risk. And yesterday I changed the slide, and you see it is in the market in Slovenia. I don't know, deflagin is, I can talk with, it's very famous. In Turkey there is some publishing data. If you ask, I can show you. But you see, it's very strong. But in real time, it does work. Yes, it's retrospective. Yes, it's retrospective. Yes, it's very small. But I think it's a very homogeneous patients, 14 patients. You see only near the 60% pap smear and colposcopy, there is a healing with the deflagin. And you see only 30% HPV negative and 70% HPV positive. Half of them is partially, there is no HPV, there is only 1 or 2. And you see the statistics. Negative pap smear after the statistic is significant. Negative colposcopy is better with the Yag Lazer. There is no significance, statistical significance, but the number is very low. But you see, there is, you see, no, okay. You see this half and 30%. And as a result, Yag Lazer is highly effective. It may reduce the viral load of the patient. Even there is no colposcopic problem, you can do for the reducing the viral load. Instead of monitoring the patient, CIN1 and CIN2 under the age of 30 is very good choice, very good choice. And the other things is recurrence. For example, if all the margin is negative, endocervical curettage is negative, but HPV 16 is positive, at the end of the 1 year, 10% of the patient, there is a recurrence. What is the recurrence? Is CIN1, it comes like that. And we are monitoring this patient. Don't monitor this patient. Use Yag Lazer treatment. Okay, it's very good. And this is the last one. I have a time? No, I have. Okay, this is, if you want to, we are programming a study like that in the university. Is very good. Is we call the EVAR study. If you want to participate in this study, please write to me. We are writing material, method, etc. And this is some study, pelvic radiotherapy after the vaginal rejuvenation. This is our study because this is the whole package. This is the whole package. If we can discuss for the endometrial cancer, but systemic hormonal, but for the cervical cancer, rectum and anal cancer, you can give the systemic hormonal therapy. You must give the systemic hormonal therapy, and after that you must use vaginal mode with the E3, and after that for 3 months or 4 months you can use the laser, and after that hyaluronic acid injection. At the end of the 8th month, you can unbelievable vagina. After the radiotherapy is working. This the whole package is very, very, very good things. And last sentence from my close friend Egemen Koyuncu. She's not here, but One day she said that it will be perfect. It could also make a coffee. I don't know. Maybe someday. Thank you so much for your...
Thank you for this wonderful presentation. I think we have time for a question or two if there are questions from the audience or comments from the audience.
Thank you for your presentation. I was asking about because when we do the laser, we have no histology after, because we destroy the location of the lesion. No, so how we can do the...
No, we have a colposcopic biopsy before and after. If I don't see any lesion, I can take a biopsy. Because of this, I can show you
with the lesion 2, VIN3 or CIN23, the conversation that we are sure that we take out all the cancer. But
there is no conversation here. There is no conversation here.
I know. It's a question.
What is it?
It's just an observation. With the conversation, we are sure that we take up all the neoplasm.
Yes.
But with that, we are not sure. For example, when we have a multifocal lesion,
yes.
How we can be sure that we
because of this,
take up all the...
Because of this, we are doing for the CIN1 and under 30 years old CIN2. But here, we are doing pap-smear, colposcopic biopsy, and HPV. After that, pap-smear and colposcopic biopsy. Okay, if there is a problem, for example, I see a problem, I take a biopsy, it's CIN2. And after that, and HPV typing. Okay, and all of this patient, at the beginning, we are doing endocervical curettage, always. But this is CIN1, we don't have CIN2 under 30, we don't have any any endocervical curettage positivity. Okay.
So, is this exclusively for age under 30, or you performed also these procedures in the ages over 30?
Over 30, we are doing conization for CIN2.
Because we have to bear in mind, with the respectable sexual behavior in patients that we do not perform anything, just the condom and something. In younger patients, it will, in 30-35%, it will resolve by itself.
Yes, always there is some things like that. This is the possibility. Even CIN3 can regress. But the problem is over 30. For example, there is a German study, it's a very good study for 300 etc. patients. It's very good, and is compare under 30 and over 30. Is over 30 more than 67% of the patient go to the CIN3. Because of this, we are doing conization for the CIN2.
Thank you.
Welcome.
Okay, it's the last question.
Thank you for the presentation. I just want to ask you that, is this a one-time treatment? You do the vaporization one time, and that's it, right?
Yes. This is why, because we want to compare for the alternative treatment, okay? We can discuss that. For example, you can do after 6 months again. So it's other things. Other things.
So when you do the control biopsy, you say that first you do.
We call the patient at 3 months. You know, the woman come to 5 months, 4 months, 6 months, but late for 5 months.
In that time, do you recommend any alternative treatments or?
No. Especially no.
Okay.
If she use, we don't. No, we go out.
Okay.
Okay.
Thank you very much.
You're welcome.